Pivot.
I'm gonna go get the
I think this is where I jump in, and I'll just apologize at the beginning for being in a noisy environment. I'm in an airport getting ready to take off on a flight, but I'm Marty Hatley. I'm a co-founder of Patients for Patient Safety US. I'm a longtime patient safety activist. And all of our founders are. We've been around since 2021. We are also patient and family led and driven. And we came together really to to reaffirm and recreate and reinvigorate patient and family engagement as a driver of patient safety. And patient safety is as a national priority. We felt it had drifted after the Obama administration was over. When Biden came in, he didn't prioritize it fast, and so we got to work and just took our message to his administration, to Congress, and we're preparing, frankly, to do it again with a new administration and a new Congress. So that's who we are. Next slide, please. I don't think I'm advancing slides. Oh, I didn't actually say much about Project Pivot. So one of our projects, the way we're advancing our work is a project called Project Pivot, which is really looking at what patients and families would want to report if they had good vehicles for reporting the things that matter most to them. And we'll be walking you through that project. We're really thinking about HCAHPS surveys as a reporting pathway. It could be other research kinds of projects as well as other reporting projects. So that's what Project Pivot's going to be about, and you're going to hear my wonderful colleagues talk more about it today. So we're funded for this work for Project Pivot by, back to that slide, by Gordon Betty Moore Foundation, John A. Harper Foundation, the Jewish Healthcare Foundation, as well as PCORI. We're very grateful for the funding. It really is our first big project, and it's going, it's surpassing all of our expectations and how much buy-in and how much interest we're finding about reporting the sorts of things that we think patients and families want to report. And it's crucial because there's underreporting of the kinds of things that we want to report. So we're going to fill a big gap when this gets implemented. Now the next slide. I mentioned that we came together in 2021, and one of our vectors was a new Global Patient Safety Action Plan out of the World Health Organization. And the first plank in that plan is making patient safety a #1 priority, public health priority in your country. So we gravitated to that and have been running with that ever since. Next slide, please. Presenters today, a wonderful group of people. I mentioned that we were patient-led, but this network is open to anybody who is passionate about patient safety and who sees the value of working with patients and families. So really living your entire constituency, there's a place for you in our organization if you want to join us. We do orientations that are about an hour long every month. We do 3 months. You can join us and become a Patients for Patient Safety champion. There's no cost. You can leave anytime. It's the easiest organization you'll ever join. Again, the criteria are being passionate about patient safety and then wanting to work with patients and families. So I've already introduced myself. I'm a co-founder and the director of policy and advocacy. Sue Tran is a lawyer. She is a patient with a lot of experience herself in navigating the healthcare system. Also a caregiver for a spouse who is now undergoing some pretty significant activity in healthcare. I don't want to say too much, Sue's, but a phenomenal advocate for many years on patient safety issues and patient and family engagement. Vonda also comes to us because of a medical error that took the life of her beloved husband, Charles. She's an organizational culture expert who does a lot of work with just building the kinds of cultures we'd like to see in healthcare. And she's been a phenomenal contributor to Project Pivot. Divi is a physician with a huge interest in missed or delayed diagnostic excellence. And he's just become a very, very valuable part of our team. He's at Geisinger, but research interest really throughout the diagnostic safety space and the patient safety space. So a wonderful team of people that we get to work with, very exciting. Okay, next slide. Our objectives today are to describe Project Pivot and the themes that we're really trying to drill down on, and the populations we're really trying to drill down on as we think about who doesn't report, who could report, and what would they want to report. And then our project will take you through this, but we're going to tell you how we're doing this project. We're trying to identify questions that we could plug into things like HCAPS, and then identify the gaps that exist and need to be filled. And then we're going to talk a little bit today about why Project Pivot, and engaging the patient voice in contributing to not only reporting of safety events and bias events, but also improvement work is part and parcel of our culture. And then again, there's a lot of ways you can engage with Project Pivot or with our other organization as a whole. And we hope that you'll be motivated to do so by kind of engaging with us today. Next slide, please. And this is where I think I transition over to you, Suze, and I'm going to go on mute and say goodbye. And Barbara Lewis, I saw you in the participant list. I'm going to be doing your survey on my plane home today. So if you haven't heard from me, that's why, but it's going to be done.
Oh, thanks so much, Marty. Really appreciate it.
Great to work with you all. Have a great rest of session.
Great. Thank you so much, Marty, and safe travels. Thank you for getting us kicked off. Hello, everyone. As Marty said, I'm Sue Schrant. I'm a Patients for Patient Safety U.S. champion and one of the co-leads of Project Pivot. Have a long background, as you heard, in patient advocacy and patienthood. Myself, I come from the rheumatology world. I've had a form of rheumatoid arthritis since late childhood, and now am the caregiver for my terminally ill husband. So I'm seeing the healthcare system really from a whole new side. So it's really a privilege and an honor to get to do this work because I'm called to it in a number of ways. So really just grounding again in the goal of Project Pivot. The idea is to integrate new questionnaire items related to patient safety, diagnostic safety, and discrimination and bias. And Marty mentioned HCAPS, and we are sort of, as a first exercise, really focused on HCAPS, but we see utility for the work we're doing. This is sort of the idea of planting 1,000 flowers everywhere. I think this can, as we develop methods and models for doing this work, for identifying these important questionnaire items to embed and integrate, that can exist in a number of places and should exist in a number of places. And you see the underlined portion here, the real, the spirit of Project Pivot is that this is about identifying what is important to patients and communities. So we can go to the next slide, and I'll give you kind of a bigger picture for how this started and what it looks like. So why do we think this is such a big deal? Why is it so important? The idea of collecting information directly from patients and families is not new. And in fact, the HCAPS tool has been around for a long time. There's widely recognized value in hearing directly from patients and caregivers and family members. But the historical method for doing that is by developing tools that are not co-created with patients and community members. There might be a few patients in the room, a few people with lived experience contributing to the thought and the engineering of these tools, but it's certainly not patient-led or community-led. And that's what we're really trying to revolutionize here. So instead of starting with sort of that traditional model where you would do a literature review and see what exists, and then from that figure out what to use, we started by talking to patients and communities and saying, what's happening in your worlds? What are you experiencing? And what do you feel is not being captured? And what do you want to have captured? So we flipped that paradigm. And so clearly that fills an important gap because we're collecting data that has not been captured in existing data sources or existing tools. This really provides a more holistic understanding then of the patient experiences and outcomes. It's very easy to sort of get narrowly focused on what we would think of as sort of pure clinical outcomes, but we know harm exists in many ways. And so we want to understand the entire experience of care, the entire experience of the diagnostic journey. And safety and equity are so aligned. This really is the if we're looking at payment methods and that how we reimburse for safer care, reimburse for equitable care, having this data is mission critical. There's no way we can truly effectively match payment with high value, safe care that is equitable unless we know from patients and communities what constitutes safe and equitable care. Our goal is that this also increases transparency. Even just the act of being able to report, of knowing where to go to report, feels very important to us as patients and then to the folks that we've talked to in the course of this work. We believe this has the power to enhance research and quality improvement, of course, and it really effectuates safety and equity policy. If we are putting patients and families and communities at the center in that leadership, in that driving role, then of course policy will follow suit. So that's sort of how we got here. So if we go to the next slide, there's a lot on this slide. We're not going to be quizzed, but this gives you just a snapshot of where we are. This is really a living, breathing concept. I don't think there's ever going to be an end of Pivot. It will just have several, metamorphosis along the way. But there are a few phases, and even the phases overlap to some extent because there's always new learning being generated. But phase one started with and continues to be building community. So making a very large tent. We want to hear from everybody. We want to pull everyone in, but always making sure that patients and families and communities are really at the center. We don't want what patients or communities offer up as important to ever be sort of voted off the island. Those things need to be held, held near and dear, and they need to be sort of that North Star. That's why they're in the room, to tell us what's important. Next is this phase two, where we collect existing survey items, because there may be some things that could work and really align with what we're hearing are important things to consider. But we also reserve a place for developing new things. We don't want to be limited by only being able to use what currently exists. So phase two is about collection and really hearing from anyone who has ideas or suggestions for those existing tools. Phase three is about mapping, organizing, and prioritizing. And that's really what that funnel symbolizes in the middle. This needs to be a collaboration. We want patients and communities at the helm. We want them to tell us what's important. But we also want to know from everyone else fighting for safer, more equitable healthcare, what would be valuable to you in your healthcare system or in your research? What would be helpful for you to know? And so that's why you see so many different types of partners in that funnel graphic. And then we'll go through prioritization, figuring out things like how and when patients want to report. It's not only about having the right questions, it's about asking those at the right time in the right manner, creating a place where people feel safe, that there won't be punishment or retribution for reporting unsafe or unequitable care. And then phase four, and again, all of these, I could make an argument that none of these phases will ever be done. It's just going to keep growing, keep evolving. But phase four is about publicizing and mobilizing. I think one of the things you'll hear in any discussion about Project Pivot is that we feel it would be a true injustice for us to just do the front end work, identify questions, suggest places where those should be integrated and used, and then not see that come to fruition. So that phase four is really, when we say mobilize, we really mean it. We want to push, we want to pilot, we want to integrate, we want to see uptake, and then we want to see how it works and what it looks like in practice and what we're learning, because we believe there will be continuous improvement opportunity. Okay, so we can go to the next slide. So we had a large in-person launch. We've had many, many different engagements, and at the very end, we'll reiterate the many ways you can become involved in this project. We had a large in-person launch in September. Oh, okay, sorry, I think we had someone unmuted. But it was the energized comment, so that it's good to get that energy late on a Friday afternoon. We had many, many different types of people in the room. It was a really dynamic and fantastic event. And then we've continued to gather additional insights since that time in September of 2024. And so on the next slide, I'll walk through just a couple of the overarching categories that that kind of rose to the top as people shared their ideas through a number of exercises and discussions. So things like events that led to the harm or the near miss, so those sort of big picture topics, but things like culture and linguistic competencies and how that if you sort of follow that path all the way to the harm or inequitable care. Things like lost test results, lost tissue samples, errors in the medical records, so sort of more technical than adaptive problems. Physical, emotional, psychological, and financial harm to patients and families, and how that impacted them. That the harm does not end at the moment that it occurs. The harm has sequela for, weeks, months, years. Patient and caregiver engagement in decision making and informed consent and access to accurate medical records without information blocking. We hear many, many, horror stories about being denied access to even your own information under the auspices of HIPAA or other privacy or regulatory concerns. We know that that is a big issue that we need to address. How a harm event was managed by the healthcare system, that really matters. Just knowing that someone's listening and something's going to be different in the future. Other people won't go through what you have gone through. That's a very important factor. Of course, underlying so many different harm experiences, bias and discrimination or stigma due to race, ethnicity, gender, disability, weight, disease, age, etc. Perception of safety and trustworthiness of the healthcare system, accessibility and accommodation for special needs, the cover up of medical error, the lack of accountability, and that really gets to the heart of Project Pivot. We want to bring this into the sunshine, be able to, we can't address it or solve for the problem if we aren't talking about it out loud, and we can't talk about it out loud if we don't have mechanisms for reporting. Being dismissed, ignored, disregarded, disbelieved, stigmatized, disrespected, all of those are paramount issues. Inadequate patient education, support instructions, how to escalate care. That's such a recurring theme. And discharge planning, that notion of kind of falling off the cliff when you get out of the hospital, and that you feel like you've got your support in hand, and then the first time you go to make a phone call, you end up on hold for 30 minutes and you don't know who you're supposed to talk to. Timeliness and accuracy of diagnosis, triage, and treatments. This includes delays from the pre-authorization process. So as we started to gather all of these concepts and ideas, we see that there are sort of concentric layers. So it's not just the experience between me and my healthcare team, it's all of the other parts of the system that contribute to delays or blockage. Continuity and coordination and care between providers, those dangerous drop-offs when we get, handed between providers or even in the inpatient setting at shift change, information getting lost or changed. And then whether or not patients were informed where and how to report patient safety incidents. Again, that's another one that's sort of bedrock for us. We have to not only develop these systems, but then publicize them and make sure patients are aware and that healthcare systems are committed to using them. And then down the road, when we build out these research tools, same thing. We want this to be an expectation when research and QI is performed that these types of data points are being gathered. Okay, if we go to the next slide, I think at this point I'm going to hand it over to Divi. Thanks so much, and I look forward to some discussion at the end of the session.
Thank you so much, Susan. Good afternoon, everyone. Appreciate the ability to kind of participate and learn along with all of you. The one thing Marty was very kind in his introduction, but the one thing that brings me here is the intent to operationalize a lot of what we see in research. There are 2,500 papers that come up on Google or PubMed. But what really upsets me or kind of sometimes motivates me is the fact that we don't see a lot in implementation. There's study after study, paper after paper, and author after author. People have made such great contributions, but it'd be lovely to actually see things translated into action in order to improve patient safety. Because I go with the philosophy that these patients are no one but us, our families, our friends. So this title slide here, it says 100 years later. My background is in medicine and policy, as it was introduced. I can give you a very quick story. So when I got into this, in studying this subject of specifically diagnostic safety, where we study missed, delayed, or incorrect diagnosis that may or may not result in harm, but the point is there is some learning opportunity there. I was surprised when, nearly about 13 years ago, when I started working on this, my mentor actually told me that this is an interesting issue and we should write something about it. And we did. But the point was, I discovered a piece that kind of validated my concern. And my concern was that diagnostic errors were not new. Neither were they new, nor are they going to go away anywhere. I know it seems very stupid to say something like this because, this, I don't mean to be condescending in any way. The point is, the very nature of medicine is that it's shrouded in uncertainty. Medicine is not black and white. There's a lot of gray in medicine. And in sometimes dealing with this uncertainty, we sometimes delay or miss certain diagnoses that may or may not cause harm. So when it says 100 years later, I found a piece in JAMA from Dr. Richard Cabot that said, this is 100 years ago, somebody already wrote about misdiagnosis. So it's not rocket science. It's not a new concept. In fact, his quote here I have in front of me, it says, a goodly number of classic time-honored mistakes in diagnosis are familiar to all physicians because we make them again and again. Some of these we can avoid, others are inevitable, but all should be borne in mind. And we should mark in our mind, dangerous turn here, go slow, or in this vicinity, look out for hidden rocks. So I just brought up that point because that was in 1912 in JAMA, and here in 2015 at the IOM report that came out for improving diagnosis in healthcare, one of their conclusions was that very few, if any, healthcare organizations have processes in place to identify diagnostic errors or near misses in clinical practices. But collecting this information, learning from these experiences, and implementing changes are critical for achieving progress. Why did I go here? Why did I kind of digress for a second here? Because, Suze and others were talking great about patient-reported outcomes and how to learn from patients, what we need to ask them. This is why. Because at the end of the day, what is all this going to impact? It's going to impact how healthcare organizations, be it a clinic in an outpatient setting, an ED or inpatient setting, hospitals, they all need to understand what they can ask you so that they can continue their learning journey and make fewer mistakes as possible. That's just my, kind of a philosophical approach here. If you can move on to the next slide. I continue my philosophical theme here. Even though I represent, let's say, the health system voice, to all the clinicians and the health system stakeholders and people out there, we are already faced with, the challenges of AI, the opportunities of AI, and big data analysis and whatnot. But I present here one of my favorite papers, the data of diagnostic error, big, large, and small by Dr. Dhariwal and Shojane. It says very clearly organizations should welcome large data sets into their portfolio. And you do lots of innovative work, you measure diagnostic error, that's great. But you cannot lose sight of this persistent problem in efforts to improve quality. And what's the persistent problem? People like to think that data will change things, but data alone cannot change practice. Who is, after all, behind the practice, right? There are two very key stakeholders. They might not be very powerful, but there are two very key stakeholders. One is the patient and the clinician. This argument is about the fact that clinicians would appreciate learning from errors. And how are they going to get this information? Apart from, patient safety efforts and structures that are already present in the health systems, it is, after all, the patient's voice. And I'm sure everybody on this call would appreciate that not always the patient's voice reaches the providers. If you can move on to the next slide, I'll give you a quote from this paper that says, clinicians quickly learn that the most powerful stories are where their own patients are the protagonists, and that patient-specific feedback is the strongest motivator for improvement. The curation and sharing of these stories should remain a priority even with the rise of big data. Technology has been amazing and has made amazing progress in the recent decades, but the human brain has not changed one bit. The story, not the statistic, remains the brain's preferred unit of learning, the most powerful tool of persuasion. Why I make these two philosophical arguments is only to help us all probably reflect, recognize, and maybe acknowledge and agree that it's beyond just the harm that so many of you and your families or other patients have suffered. That should be the precursor or the trigger for health systems to actually actively, proactively seek feedback and learn. It's the other side. It's the fact that medicine is uncertain, and the way clinicians remember and improve the care they deliver is to get constant and consistent feedback from patients. This was the philosophical approach. Very quickly, in the next couple of slides, I'm going to give you the more practical, on the ground, facts. These are things that are available out there. You call them tools, you call them strategies, but in other words, these can easily be, expected to become regulation sooner or later. For years, like I said, there's been a lot of research in the area of diagnostic safety, but how are we implementing it? How are we kind of translating it into on-the-ground implementation? All of you know that all hospitals love to do the leapfrog survey, the hospital survey. Even, it gives them stress, but still they like to, because they know that they can publicly report a grade. Grading has remained a very basic, human cognizance of the quality. So everybody wants a leapfrog grade. Now, the leapfrog hospital survey, after 3 to 4 years of a lot of work and, collaboration with national experts, they have actually come out with a section in the hospital survey dedicated to diagnostic safety. There are a bunch of questions, about 10, 20 questions that eventually are going to become mandatory to answer. Right now, they're optional. So if you work for a health system or if you are in a PFAC and you can take this information to the health system, let them know there is an optional section on diagnostic safety in the leapfrog section that they can actually, start doing, because this is a checklist of best practices that healthcare institutions can implement to, up the ante on diagnostic safety. And we have a section of a screenshot of one of those questions, and you will realize how important it is to learn from patients directly in this whole effort to improve diagnostic safety or patient safety. The patient safety structural measure. I think all of you on the call are aware, and PFPS has been a major national force, voice, and champion in pushing the legislation, pushing the rules along for the patient safety structural measure. I agreed that just attestations by healthcare organizations, but that really takes up things up a notch, because it is much better than nothing being done. In the same way, just like Leapfrog and IHI, we have put out different tools. The CDC's core elements of hospital diagnostic excellence, mostly shaped around their core elements of antibiotic stewardship and excellence. They have also, again, accumulated all best practices that can improve diagnostic safety at hospitals and put that out for use. You can imagine if there are recommendations that are backed by Leapfrog, IHI, CMS, AHRQ, CDC, big brand names, right? Eventually, this is fodder for someone looking to put a regulation in to keep a check. So this is just information for all of you so that you can take this forward to your stakeholder groups. You can move on to the next slide, please. Sorry. This is a screenshot of the Leapfrog group questions. They would love for a multidisciplinary group at the health system level to review cases, to learn from cases, and to implement, improvement strategies or the lessons that, disseminate the lessons learned. But look at question 9. Has this multidisciplinary team reviewed any clinical or administrative data patient experience or patient reported data to specifically track errors in diagnosis. I can give you a live example from mine. This is not an advertisement, it's just work that I've done over the last 8 years that I've been at Geisinger. We have streamlined the process where, patient complaints that come in, we have a very robust patient grievance unit in our hospital. We follow all, the check boxes for regulation, but we go beyond that. And what I mean is any patient writing in with a complaint of diagnostic concern, it comes to me, I run a multidisciplinary group. I take it there, we review it, we break it down, and we make sure that we learn from that concern around the diagnosis that the patient has mentioned. But that's just one example. This screenshot really is to kind of bring awareness to you that if you can pass it on to your friends, your stakeholders, your healthcare organizations, that there is a lot that can be done by seeking direct feedback from patients, especially those that have already received care at these organizations or at clinics. Next slide, please. This is an example of the very robust championship that is, that Patients for Patient Safety, this organization has kind of pushed for with CMS around the patient safety structural measures, the PSSM. Look at point number 4. They would expect healthcare C-suite leaders to attest to the fact that our hospital incorporates patient and caregiver input about patient safety events or issues, such as patient submission of safety events, safety signals from patient complaints, or other patient experience data. For a C-suite executive to attest to this means they would have to, in genuine, honest, in good faith, work towards seeking direct feedback from patient in order to satisfy this. Let's move on to the next slide, please. And look at this, snapshots of, this is a very large document, but these are screenshots that kind of just give you an idea of among the best practices, how we can engage with patients and families. Look at this on the left side of your screen, it gives you examples. You can facilitate review of records and test results in the portal, create safe and easy systems for patient families to report diagnostic safety events, include questions that can assess concerns about diagnosis and patient experience surveys. So the patient experience surveys is something that I think, we started this meeting with, because one of the goals of Project Pivot is to be able to supply questions that seek feedback from patients to improve diagnostic safety. The other example I can give is, when you talk of people throw around this word like innovations and whatnot, it's very simple. These days, even the law is set where you have to give patients access to their medical records through their portals. One of the common brand names for the portal is MyChart. So we did a small experiment at our health system. We sent patients a note saying that, hey, listen, we came to know that you had gone to this patient, this outpatient visit, and then you were admitted. Could we ask you to please review your outpatient note and share any concerns you had with us? Simple strategy, and you'll be surprised at the information you receive. Now, it's not possible that you send it to 100 patients and all 100 get back to you. But remember this, even if 5 out of 100 patients get back to you with concerns, even if half of those 5 concerns or 6 concerns are valid, you have 3 important learning opportunities that would have been just lost unless harm would have been caused. And see, this is the whole idea here, zoom out, the 60,000 foot view is we do not want harm to be caused. We do not want patients, and we do not want to learn only from harm, because harm is terrible. Imagine if that happens to us, to my family, God forbid. So, just you walk back steps and you understand how do we do this in more real time. And these are examples. I will move on to the next slide, please. I think this is when I give over the to my team, back to my team. Thank you so much.
Thank you, Divi. Hello, everyone. I'm Vonda Vaden Bates, and as Marty mentioned earlier, I come to this space as a patient advocate because of the death of my husband in 2012 from a hospital-associated venous thromboembolism that was preventable. And it's my honor to be working with the Project Pivot leadership team. It would be a waste, I think, of our efforts if we didn't take the opportunity today to also ask you some of the same questions that we have been asking since September. that will very, very much impact the work and the progression that Divi and Suze and Marty have just described. So we're going to ask you if you would either pull out your phone, or in a moment I'll also put a link in the chat. And I will go ahead and I'm putting that person on mute, but if you do have a question, certainly raise your hand and I will navigate that. If you have any questions for clarification, you can also put it in the chat. But today we're going to be asking this group to go into the poll through one of two doorways, if you will. So either put on your patient hat or put on your clinician hat, and then you'll be asked the very same questions. There are 5 of them total, and they will be focused in 4 particular areas and then 2 general questions, or 1 general question, and then just an opportunity to give us information if you want us to reach back to you with information on becoming a pivot champion. Patients for Patient Safety Champion, that is. So we'll be asking the 4 categories in, first of all, the accuracy, timeliness, and communication of diagnosis. Secondly, the experiences in discrimination and or bias. Thirdly, in the area of transparency, and lastly, in the area of patient safety in general. And specifically, we will be asking you for questions that you think might be valuable to be asked post hospitalization, at discharge in general. And these are what we're doing is taking all of these questions and digesting them and sorting them. And then there will be a process, as Sue outlined, in one of those phases where we begin to start to bring some prioritization to the questions that this assembly today and many assemblies before and several after will be posing. So with that, I'm going to go ahead and click here for this slide, and you can either take your phone and aim it at your screen at that QR code right down here in the bottom left corner, or if it's easier for you, just click on that link that I just posted in the chat. And I want to say that, these are thoughtful questions that you're going to be asked, and you don't have to ask them or answer them, rather, all in one fell swoop. I will leave this poll open for about 24 hours. So if you leave it open, you can also come back to it. And you'll notice that once you get into there, you can skip ahead, you can go back. It's all in one poll. In other words, I'm not going to click one and then wait and then click the next one and wait. Although you will start to see some of the answers pop up on the screen here in Zoom while I have it up. These responses are going to be responses from the patient's side of that doorway. So any one of the individuals here who are going through that patient doorway, we will start to see some of the answers emerging here on the screen soon. And later, I don't know that we'll have time today, but I can make a commitment to swing back and provide some of those responses back to Libby and the team if you want to do any follow-up there. So is anyone having any difficulty or trouble that needs to be sorted out? I will keep an eye on the chat, or you can raise your hand. And I'm hoping that there's a lot of people here, so I'm hoping that Zoom will help me identify if someone has their hand raised. Make that obvious and evident. Thank you, John. I appreciate that very much. We're just going to take a few moments here, probably about 5 minutes, because we want to leave some time for some Q&A with this group as well. In fact, my goodness, Libby passed along a list of questions for us, which we definitely won't get through all of them today, but really, really appreciate the engagement even before you arrived here today. And now I can see that we're starting to see some of the responses pop up on the screen. I'll leave it here, and then I will, in a few minutes, I'll start to scroll through the other few questions specifically related to the 4 topic areas of diagnosis, patient safety, transparency, and bias and discrimination. And I'll just flash forward here to see if we're starting to see some questions pop up around transparency. These are questions that are popping up around discrimination and or bias. And some questions related to patient safety in general. And then that 5th question is around just in general, what questions? This gives us a sense of how you would prioritize, what questions you would prioritize that might bridge across these topic areas, or maybe relate to something that is not in one of these 4 topic areas. For example, medication, that could be an entire subject or topic in and of itself, to be sure. And I'll give it a few more minutes here. There are quite a lot of us here. I want to make sure that you have some time to give this some thought now in case you're not able to come back to this later. I know for me, I like to give these things a little thought sometimes. I'll come up with something after participation. And I'll scroll backwards if you're scanning for some of the questions. I'll scroll backwards to some of those questions again. And in just a moment, we'll go ahead and wrap up here and we'll turn it over back to Suze, who I think will, or maybe it's Libby, somebody will roll us through the questions. But Suze, I think you have maybe 1 or 2 more slides to conclude. Is that right? Do I have that right?
Yeah, I know I've got one about how to engage with the project, and then maybe back to Libby to dismiss us officially.
Okay, that sounds good. Again, everyone, this poll will stay open for a while. So if you need a little bit more time with it, the poll will be waiting for you there. And I'll go ahead and move this to our last slide, Libby, preparing you, Libby, for we're almost complete with our slides.
Great. Thank you so much, Vonda. I always love going through these exercises. You're so such an artful facilitator of these polls, and it's great to see everyone's input and ideas. You've already kind of experienced one of the ways that we are working to engage with folks like you. So I'm just going to share kind of the whole suite of options. So you can join Project Pivot to serve as a liaison to your healthcare system or organization, and that can really take any form. You know, you can kind of define liaison in a way that best works for you. I think of it most frequently as just bidirectional communication. So you're bringing information and ideas to Project Pivot, and we are sharing information and ideas back with you. You can also contribute to the creation, dissemination, and analysis of surveys, focus groups, et cetera, within your healthcare system or organization. So you could be sort of a tentacle of the project and help capture and pull more data points in. We're still very much in sort of that collection. We don't feel like we'll ever be done collecting. So we would love to just keep hearing and learning from you. Providing feedback on feasibility of proposed survey questions and potential barriers, and this might be particularly resonant for those who are in healthcare systems, who are in the business of patient surveys. What barriers have you faced? How have you overcome those? But also for patients and patient groups, when you think about survey fatigue, how do you engage your communities to keep coming back, keep responding to questions, especially in the midst of, significant healthcare events? And then disseminating project findings and helping us advocate for uptake of project outputs. And you'll remember that very busy sort of dynamic graphic. That bottom portion, number 4, phase 4, was really about publicizing and mobilizing. And so that is a huge role for anyone who comes under the tent, is we're going to have to push in a lot of directions for uptake and use of the questions that we identify, the whole concept of embedding these questions in HCAPS and in other tools. So really, any way you want to be involved, it's open to you. These are some of the more sort of formalized ways, but thank you so much for just your attention and your input today. And please don't hesitate to reach out to any of us with questions or ideas. Is that the last slide, Vonda? I think it is. Okay, great. So I will hand it back over to Libby, and thank you all again so much.
Knew I forgot the mute button. Thank you, Suze and Vonda and Divi and to Marty as well. That was a great presentation, and importantly, a great invitation into patient safety and the Pivot project. So I think we have a couple of minutes for questions. If anyone has a question, they want to raise their hand or put it into chat. Nadine.
Yes, I'm sorry to have to bog down this wonderful presentation, but I went through and answered all the questions, and then I accidentally went to the Q&A section. Now I can't get back to my answers on 1 through 5, and I can't start over again. I've tried both on my phone and on the link.
Nadine, this is Vonda. I'm going to put my email in the chat, and also
Right.
I'll do a little bit of study on my end to see if maybe it's there and you're just not able to quite see it. So I'll help troubleshoot with you on that. Thank you.
I sure appreciate it. Thank you. And my other, if I can hog this time for a second, Dr. Divi, because I can't pronounce your last name, you are just so awesome. And I want to ask you if you feel like, I just love the Swiss cheese model, both for clinicians and for patients, to really drive home some storytelling in conjunction with storytelling. Do you make use of that very much?
I think yes. Many healthcare systems and many people in risk and patient safety often use the Swiss cheese model, and sometimes, unfortunately, the fact is we do see missed opportunities and patient safety incidents where we actually see, some classic Swiss cheese model, where things fit into the classic Swiss cheese model. So yes, we do use it. I appreciate the comments there.
Thank you, Doctor.
And if I could just take one of the questions, I think we have time for one more off the list that came in during registration. Do any of you have thoughts on, how do you see AI improving the situation? How do you see the impact? Or is that maybe something that you're just starting to ask questions about as well?
Can I
Go ahead, Divi, and
Sure.
then
I'll just make a quick reference. I don't know if it's online yet, but I'm sure we can circulate the link. Just yesterday, or maybe 2 days, I think it was yesterday, the University of California, San Francisco Codex had a wonderful discussion just on this topic and how it relates to patients engaging and what contributions patients can make with AI. I highly recommend you watch this. It's a 1 hour, very worth, especially. And if I may channel our collective, this team's collective inner Sue Sheridan's. Sue Sheridan gave a wonderful, very powerful talk where she talked about the concept of patient-powered, technological advances that drive healthcare, that drive patient safety, but patient-powered rather than just patient engaged. Just wanted to put it out there. I'm sure there's a YouTube link that can be easily made available.
Wonderful. I appreciate that. We'll certainly circulate the link following the webinar. I think we have time for one more. I saw Karen's hand up first. Go ahead.
Yeah, good afternoon. As a DES daughter, I've started using AI to look at my genome. In particular, my HOXA genes were affected, and my physician was prescribing or ordering DNA for me, which yay. But then I wanted to know which HOXA gene, so I did an AI search and found, HOXA 13, and I connected with the DNA company, and they can do that one. So that's all they could do is the one, but one's better than nothing. So AI is helping.
That's great. I'm glad to hear that's helping for you. All right. Well, I think that pretty well takes us to time, but just want to thank our presenters today. That was a fantastic presentation, and hopefully the first of many conversations between our two communities as we all are, doubling down on patient safety in this critical time. So thank you. A couple of quick announcements. So many of us have been missing our annual conference. We haven't done it since I think 2022, and we are super excited to be collaborating with the Camden Coalition to be a co-content presenter at their Putting Care at the Center 2025. So I want you all to put this on your radar because it's going to be a great conference of very like-minded folks and those that will really push us to be thinking about how we implement truly person-centered and patient family engaged care. So the registration is not quite open yet, but the request for proposals is. So please take a look and join us in Portland. We're really excited about this partnership. All right. And then next month, you heard Divi and Suze and Vonda speak to the patient safety structural measure. We've been working with our community, both our PFA network members as well as our clinical partners and health system partners to develop the ACT framework, Advisory Councils Transformed. So really looking at a very inclusive framework for developing patient-family partnership programs that meet our diversity, meet the needs of organizations with fewer resources, and really increase the impact of patient-family partners. So looking forward to bringing that framework to you at the end of March on this community of practice. And with that, from our team to yours, thank you for spending an hour with us on a Friday afternoon. And you can see this and all of our community of practice programs on our YouTube channel. We're on Instagram or stay in touch on LinkedIn. All right. Thank you so much to everybody who's joined us, and a big warm thank you to our wonderful presenters today. Much appreciated and much follow-up to come.
Thank you, Libby. Thank you, everyone. Have a good day.
You
Thanks
too.
so much, everyone.